Hello and welcome to WEO's first webinar in 2022 on the topic of treatment of esophageal squamous cell cancer. This session has been organized by WEO's Esophageal Diseases Ad Hoc Committee. Without further ado, I'm handing over to chairs Prateek Sharma and Cesare Hassan.
Okay, thank you very much, Alex, and good morning, good afternoon, good evening to all our viewers of the WEO. I'm Prateek Sharma from Kansas City, and it's my pleasure to host this along with my co-chair, Professor Cesare Hassan from Milano, Italy. Cesare, as you know, is one of the leaders in the field of gastroenterology and epidemiology and also artificial intelligence. And it's always great to have Cesare on board. Besides adding his scientific content, he'll also add some humor to the webinar today. So Cesare, welcome. My pleasure to do this.
Thanks, Prateek. And we have an outstanding panel and a great program. Please, any can drop the questions on the chat, because we have a discussion after each topic. So just start with Professor Lawrence Ho from the University of Singapore. Welcome. And let's talk about the epidemiological of SCC before we get into technology. Thanks, Lawrence.
So thank you, Cesare. Before Lawrence starts, Cesare, there's just some background noise, so please be careful when you turn on your microphone. But just before we get into this, I just wanted to open it up for our entire panelists who are here, as well as the speakers. So keeping in line with the global audience, as well as the World Endoscopy Organization, we truly have experts from around the world, from all different continents. We have Roberta Maselli from Milano, Italy. Roberta, if you want to wave to the audience. We have Majda Bukhari, who is now in Dubai and is joining us as an expert from the Middle East and African subcontinent. Lawrence Ho, who will be starting us off very shortly, is from Singapore. Fernando Fluxa, who is the president of CIED and our neighbor just a little bit south to the US from Chile. Sergey Kashin from Russia, again, one of the leaders in endoscopy there. And of course, Haru, who we wouldn't be here talking about endoscopic treatment of esophageal squamous cell cancer if the JGS president had not taught us how to do endoscopic mucosal resection, which he started off several decades ago. So welcome to everyone. And Cesare, over to you to go over the list of topics and start off us. Thank you.
Thanks, Prateek. And let's start with the first topic, that is SCC East versus West, with Lawrence Ho as speaker. Welcome, Lawrence.
Thank you, Cesare. Thanks also, Prateek, for this introduction. So I'd like to thank WEO for this privilege to talk to you today on my topic. So I'm going to start off with sharing my screen first. So my topic, as you can see, is on the screening for esophageal SCC. I kind of choose to contrast the West versus the East because you'll see later on why. In any case, these are my learning objectives. I hope to take you through systematically to try to explain to you at the end why screening for esophageal SCC is important. So firstly, on the epidemiology, and this is interesting. And as you can see from this particular slide, the Asia standardized incidence of esophageal cancer. This slide is taken from 2019. As you can see, varies quite widely across the globe. It's probably highest in this particular area, which is termed the Asian esophageal cancer belt, where the incidence is as high as more than 1 in 1,000 individuals annually. As you probably know, SCC accounts for 80% of the esophageal cancer cases worldwide. So it's not surprising if you look at the Asian esophageal cancer belt, China represents more than 50% of the so-called global burden of esophageal squamous cell cancer. And this is important. But the good news is, obviously, in Western countries, the incidence of esophageal squamous cell cancer has been declining over the last 3 decades. And then along with that, obviously, people know that the incidence of adeno-CA has been rising instead. Over in the East, the trend is also apparent. So esophageal squamous cell cancer is also gradually dropping in Asia as well in the last few decades. So obviously, I think in summary, there has been a gradual decrease in the esophageal squamous cell cancer incidence in most developed countries in the West, and also in some parts of developing Asia. But the interesting question to us is, why is this happening? And this takes us to my next topic, which is on the risk factors. So I think if you know, this particular slide shows the more important risk factors for esophageal cancer. Of all these risk factors, smoking and alcohol use account for most of the risk factors attributable to esophageal cancer. So it is believed, because of these two biggest risk factors, it's believed that the decrease in tobacco and alcohol intake, and perhaps to some extent improved diet and hygiene, and also the reduction in environmental pollutants has contributed to the drop in the incidence of esophageal cancer worldwide. However, despite this drop, the bad news remains, and the reason is that the esophageal cancer has a dismal prognosis, and latest data show survival is still relatively low, 12% at 5 years after diagnosis, and this is bad. And this is why I think it's important to again emphasize that screening remains the best strategy to actually manage this condition. And that brings me to my next topic, which is on screening for esophageal squamous cell cancer. I'm going to now contrast between the West and the East, and perhaps just briefly mention that endoscopy is the gold standard for the detection and diagnosis of this condition. And later on, I'm sure Roberta will be talking a lot more about the use of endoscopy. So I'm going to just focus on the screening, and just to kind of highlight that in the West, the incidence of esophageal squamous cell cancer is low. So the risk is actually low, and the risk is even lower among the general population. So this is why, as far as population screening is concerned, it's thought to be impractical because of the low incidence of esophageal SCC in the Western countries. In fact, there are no Western studies suggesting that endoscopic screening for esophageal SCC is either necessary or cost-effective. So that's why there is a position statement issued by ESGE. I don't think there's one by the American counterpart, but indeed from the ESG position statement, the recommendation is endoscopy screening may be considered only in high-risk individuals. However, the position statement doesn't actually specify the best time to start screening, and neither does it specify as to what the surveillance intervals exactly are. So I think that brings me back to the last topic, which is on screening in the East. Okay, I mentioned before, the East has a lot more cases of esophageal SCC. That explains why I think a lot more publications come from the East, especially from China. So indeed, if you look at this slide, which I just summarized from a few bigger studies, this slide summarizes on the so-called population screening studies on the effectiveness of screening of esophageal SCC in China. And I just want to say that I think these studies have big numbers. They use a lot of people in the population. And in the interest of time, I'm just going to summarize the main points, which are these particular studies are all large prospective population cohort studies. They all show endoscopic screening decreases the incidence as well as the mortality of SCC in the high-risk areas in China. And the screening has also been shown to be effective in detecting the so-called precursor lesions and increasing the survival rate in asymptomatic population in those high-risk areas. So recently, there's one, not so recently because it's been going on for about 10 years really. There's one RCT trying to answer the question whether population screening is effective in the high-risk areas in China. Preliminary results show that quite a lot of high-grade lesions were actually detected. But we are still awaiting the full results. So obviously, I think these are effectiveness studies. But more important question is the cost effectiveness, obviously. And again, I think there are quite a number of studies conducted in China. I'm just going to list two of these so-called studies to answer specific questions. So Yang in 2012 tried to answer the question as to the screening strategies. He sort of compared 12 screening strategies and then finally concluded that the screening which was most cost effective was a screening which so-called began from the age of 40 years at intervals of 10 years. So all screening strategy actually save life years, but this is the most cost effective of all. And the other study was conducted by Hull, looking at 3 screening strategies using different so-called endoscopic methods. And the conclusion was the Lugos iodine screening was probably the most cost-effective way of picking up early esophageal cancer. But I just also like to say that several of these cost-effectiveness studies actually shows endoscopic screening is cost-effective in areas of high incidence of esophageal squamous cell cancer. So with that, I'm going to finish my talk here with a few take-home messages, as already mentioned. Firstly, esophageal SCC is predominantly an Eastern disease, and the esophageal SCC has gradually decreased in most developed countries in the West, and also in most parts of developing Asia, mostly due to the decrease in the tobacco and alcohol intake. In Western countries where the incidence of esophageal SCC is low, endoscopic screening may be considered, according to some guidelines, only in high-risk individuals. In contrast, in the high-risk areas in China, endoscopic screening has been shown to be effective in detecting early lesions and also in decreasing the incidence and mortality of asymptomatic populations. So it's also shown to be cost-effective in some of these areas. So I think with this take-home messages, I'm just going to say thank you.
Okay, Lawrence, wonderful, very well done. As always, clear message, very easy to understand and follow for, I'm sure, all our participants and listeners. To all the participants, please put in your questions in the Q&A section, not in the chat box, so Cesare and I can get to it. So Fernando and Majda, if you are also available, please let's have you join as well. And we'll spend a few minutes talking about this and not about the modes of screening, because Roberta will go over that. So Cesare, we'll start off with you for this session, please.
Yeah, thanks, Lawrence, for your very clear data.
Thank you.
If the disease is declining, probably there's no need for screening at population level. It doesn't make any sense to screen for a disease that is already somewhat disappearing. But for a high-risk subject, you came to the point that it is not clear at what age we should start and with which frequency we should proceed with the screening. Do you have any idea what I should recommend a heavy smoker or a person with alcohol abuse, 40, 50, 60? Do you have any idea?
Yeah, I think it's interesting. So it's very much dependent on the area, obviously. I think what I can just say that in China, obviously, I think even without smokers, even among non-smokers, I think in China, the smoking rate is actually 50%, by the way. So even among non-smokers, it's recommended that screening should start in 40 from 40 years of age in those high-risk population. Whereas in the rest of in China, it's still not certain whether this is actually 40. So I think it's very much dependent on what we consider from the local data. So my hunch in Europe is probably going to be 50 years old. Again, a lot of publication emphasize that I think it's going to be opportunistic screening and unlikely to be population screening in the West. It's going to be opportunistic, and they think that we should link it onto other screenings, such as for other cancers as well. So 50 years, I think is a safe age for the West.
Yeah, very clever, like colon,
smoking,
etc.
Smoking.
Yeah. So good. So we talked about East and West, but how about going right into the center, into the Middle East? So Majda, how about in in Dubai, in where you were before, in Saudi and stuff? What's the position there? Do you do any screening for squamous cell cancer of the esophagus?
No, as actually Lauren said that the incidence is decreased. We actually not screening for them. But I had one patient, and I want to ask you guys, because I have patient with history of cancer and treated, and then when we did the endoscopy, there was no recurrence, but then she had epidermolysis, epidermoid metaplasia. So this epidermoid metaplasia has risk of cancer. So, but in this situations, I don't know how we can bring her and do screening for her. I know that it's coming and rising, this epidermoid metaplasia, but I don't know how frequent we should screen those patients.
Lawrence, any suggestions for that?
Yes, I think this is one of the risk factors, actually, well-established risk factors. Similar to, I think, screening, obviously, for things like achalasia is also a risk factors. I think epidermoid bullosa is a risk factors. I think generally is I think there's no clear kind of guidelines. It's thought to be, I think, depending on the age, maybe 2 to 3 years. That's sort of every 2 to 3 years.
Even if she had a history of cancer, you just do it 2 to 3 years. You will not do it more frequently. I'm just like
no. I think if she has a background history of cancer, which makes her a bit more at risk, I think yearly is probably the more reasonable thing. I didn't hear the part that she has got a background history of cancer.
Yeah, she had cancer and treated, and then she came for follow-up. Sure. And then she actually had epidermoid metaplasia, which kind of interesting.
Okay.
Actually.
Yeah, I think with the metaplasia, which is a bit interesting because I think this is something we have to take note of. Yeah.
So there are a couple of questions in the chat box before we get there, or in the Q&A. Fernando, what's the high-risk population in LATAM? Is it still smoking, alcohol? What patients do you see there that you consider for screening, Fernando?
Yes, I think just head and neck cancer for screening, achalasia, but really smokers and alcoholics we don't do. There is a high-risk population, of course, but we have more problems in Latin America with this patient that the esophageal cancer is not really a problem. So we don't screen for these people for esophageal cancer. The question is that how we do that. I think the quality of the screening is some of the points of this problem, because it's not just look the esophagus. I think Lawrence can give us some ideas. If you use always Lugol, for example, or just chrome endoscopy, what do you do for a good screening?
Yes, I think this is interesting. You kind of hit the issue on the nail. because there is a publication from China as well, which alluded to this problem. I think they found a lot of missed cancers. Despite the fact that they screened, a lot of cases were missed. I think then the issue is the screening. Is the issue more to do with the screening or the effectiveness of screening? Meaning that if we do a population screening, can we actually cope with the caseloads? So their argument is that because we are trying to screen a lot of people, and then we have to try to cope with a big population load, we didn't do it properly. And then because of that reason, there's a false sense of security as well. So I think I do agree with you. I think if we want to do screening, we must make sure that I think the people who do the screening are experienced in this area. I'm sure Roberta will be addressing this a bit later on. Otherwise, it's sort of, I think the resources are not as well utilized.
Prateek, there are two questions from the audience that are very similar, and then we need to move to the next talk. Lawrence, if a patient has achalasia or did the radiation therapy for breast cancer, after how many years would you recommend to start screening?
I don't. The guidelines didn't actually say very much on when. And as I mentioned earlier, I think it's 2 to 3 years is actually quite reasonable. I personally choose 2 to 3 years. Yeah, unless there's a sort of risk factors as Majida mentioned, I think previous history, but otherwise, I'm just worried that if we kind of overdo it, and then the compliance will drop. That's the other issue we need to kind of look at carefully as well. And then as to the age, again, I think I choose about 10 years after the diagnosis or at the age of 50 years to start.
Okay, and then there's just some comments saying that in Afghanistan and Pakistan, the incidence is high and keeps on increasing. There's a question regarding precancerous lesions, and I think Roberta will go over that. So I think we've pretty much addressed all of that. There was a question related to when can you stop screening in the high-risk population, and again, I'll just say that there's no clear recommendation, but I think you just keep in mind the overall health status of the patient and stuff. For example, screening for colon cancer, and our recommendation is that at age 75, you stop it, or in some patients, you have to stop it at 70 if they have significant, comorbidities. So I think we'll take those into account. So again, Lawrence, thank you very much. Wonderful lecture. We'll move on to number 2. Over to you, Cesare.
So it's a big pleasure for me to introduce Roberta Maselli, who is the director of the endoluminal endoscopies here in Humanitas, where she's assistant professor. Roberta actually learned directly from Haru in her practical fellowship in Japan. And so, Roberta, your talk is about how to detect this lesion. Please.
Thank you. I'm sharing my screen. I hope you can see it. And first of all, I would like to really thank you for inviting me here. I'm very happy and honored, and a little bit anxious to talk in front of you, especially in front of my mentor, Professor Inoue, that invented and created the classification to detect the early SCC. But let's start with a clinical case. I want to start with 2 clinical cases because the problem is that, especially in the West, we must be honest, we are not familiar with the SCC. So most of the time, the standard endoscopy doesn't know what to look for. So this was a man of 84 years old that was referred to our center for just a gastric antral lesion that they took biopsy, and they said it was high-grade dysplasia. But passing through the esophagus, we noticed something different from a normal mucosa and standard mucosa. And this is the picture. And in white light, you can see that that is a regular mucosa throughout all the esophagus. And if we look and focus on the pattern, on the vascular pattern, and even applying the Lugol solution, we can see that there's a very large lesion that was finally an esophageal SCC. The problem is that when we went there in the antrum, we find that that high-grade dysplasia was already an invasive cancer. But what to do in a case like this? You know that in case of possible surgery, you need that stomach to be attached instead of the esophagus. So I went for an ESD just to try to give a chance to that patient, and this one was gastric cancer adenocarcinoma. So the patient came to me with just one problem, the HAD in the antrum, and he came back with two problems together. And one more case, a female of 77 years old. He was referred to our center for a focal high-grade dysplasia. And you know that the colleague called me saying, Roberta, I'm not able to find any lesion. It was just some irregularities, took biopsy, and they say that is high-grade dysplasia. And then I sent a biopsy to a very expert pathologist, GI pathologist, and he confirmed the high-grade dysplasia. So he scoped again the patient, and again, he was not able to find any visible lesion. So I asked the patient to come to our center, and this is what I was able to find. This is just with BLI that is similar to MBI. And if we look with local chromendoscopy, we have this vast and huge discolored area that was a high-grade dysplasia on SCC. So the first question is, why is so challenging to find the SCC? So the diagnosis is so difficult. The fact is that most of this lesion is very flat. It's a tallow appearance. So it has been reported that up to 40% of early SCC has been missed. And this is the problem, the morphology, and also the fact that, as I was mentioning at the beginning, we are not familiar with SCC. So the recognition of the vascular pattern is a little bit challenging for untrained endoscopists. And this is why with my presentation, I hope that I will give you some tips and tricks in how to look to find the early SCC diagnosis. Because as early as we make the diagnosis, as much we can cure the patient, because as Lawrence was mentioning in his presentation, the prognosis at 5 years is really, really poor. So the first things to remember is that usually we have a flat lesion for the SCC. So at least for the very high risk patient, we should look for any small and little irregularity in the mucosa. And in that case, then we can apply the chromendoscopy with Lugol, and before that one with a digital chromendoscopy, MBI and BLI on whatever we have. But most of all, we should have a magnification endoscopy, because with the enhancement of the vascular pattern, we can really help together like a puzzle with the chromendoscopy, with the Lugol chromendoscopy, we can have a real picture of the lesion that we are facing. So the Lugol chromendoscopy, why is so important? Because the iodine blinds the glycogen, and this is why we have like on and off chromendoscopy. It means that the lesion usually does not stain, is a Lugol voiding lesion. As in this case, you can see that the irregularity is very small and very difficult to catch with a white light endoscopy. A little bit more clear, but just a little bit with the digital chromendoscopy. But then when we spray the Lugol, it's clearly visible. And the sensitivity is very high. We have a small video. It's inexpensive, is easy to perform, so we should always have available some Lugol solution in our unit. Just go there and spray it, and it's very easy to apply and to do. But then we were mentioning also the electronic chromendoscopy as NBI, that is the most studied and oldest study as with this one, because it's the oldest and the more known. But at the same time, we are now also the BLI, or from other companies, also the iScan or the FICE. And NBI is more specific than Lugol solution and helps you in understanding and make a distinction between neoplastic and benign mucosal alteration. So the fact is that under MBI or BLI, the early SCC appears as a brownish discoloration of the esophageal mucosa. So the second tip is look for any brownish areas. Plus, it's not okay. we must remember the esophageal anatomy. So from the submucosa to the mucosa, we have different vascular pattern, and especially in the mucosa, we have the so-called IPCL, that is the intrapapillary capillary loop, and based on the shape and running shape of the IPCL, we have one of the best classification we can have from Professor Inoue, that is the IPCL classification, that based on the running and the shape of the IPCL, we are trying to make a prediction of the depth of invasion of that lesion. And this is important, this is the link with the endoscopic treatment, because based on the prediction of histology, then we can start to thinking about the treatment, if it's still an endoscopic treatment possible, or we have to send the patient to surgery or to radiochemotherapy. So this is very important to know this classification, but most of all, it's important to use the correct tools to apply this classification. And because it was a little bit complicated with a lot of different items, they make it a little bit simpler. And this is the newest classification, just with 4 items. Basically, we have to look for the shape and the running shape of the IPCL and try to make a comparison with the normal mucosa around that brownish area that we are looking with the digital chromendoscopy. So one more case, this is a male of 73 years old, and you see that on BLI, I have a part of lesion that is side and all the other is flat. And if I focus, so also the zoom and the magnification is very important on that area, I can see that the running shape is very distorted. It's not in line as usual, but I can see here that I suggested that this one was an IPCL 5-3. They asked me again to treat because the patient was a little bit old and with a lot of comorbidities. And finally, it was a submucosal invasive neoplasia, exactly what the classification helped me in understanding. If you can see here, I'm using a black cap. So for the diagnostic part, again, this is the third tip, is a very helpful tool. I have here a video because it's a very soft cap. It's black, so it helps you. Oh, it's not working. Yeah, maybe it's going now. Attaching this cap that is soft and is not making any trauma on the mucosa, because the PCL are very tiny. So if you make trauma, if you let the lesion bleed, you won't understand anything on that vascular pattern. But with this one that is atraumatic, you can create a sort of a room, and using the water and the zoom, you can have a very high magnification and try to focus on the vascular pattern of that lesion. And finally, what is very new and is not so applicable everywhere because it's only in Japan and in other few countries is the endocytoscopy. Again, from Professor Inoue, we have this classification. So it's a super high magnification up to 350 times. And applying with crystal violet chromendoscopy, you can see a cells level. So it's something unbelievable that seems histology, but it's not. This is endoscopy, and based on endocytoscopy, you have this nice classification. It's not so we can't use everywhere, so we have not in our center or in Europe. But I really hope that in the near future we can use the endocytoscopy too. So to conclude my presentation, let's remember that there's up to 40% of early SCC miss. Is just for our gap in knowledge, but at the same time also because the appearance is difficult, is a flat appearance and flat morphology. Some useful tip in case of risk factor, look for small mucosal irregularities. Use whatever you have in your hand, MBI, BLI, scan, look for brownish area, use the soft cap, and remember to use the Lugo for flat squamous lesion. And finally, apply the IPCL classification because up to now is the best guidance for treatment that we have, endoscopic versus surgery. Thank you.
Grazie, Roberta. Wonderful lecture as always, and also the beautiful videos you showed us. So very nicely done. So if we can again get our expert members, on the line. Fernando, we will start with you. You were mentioning about how careful examination and what to look for in that. Do you follow some of the similar principles or any other suggestions beyond that, Fernando?
Yes, we usually use endoscopy. We always use endoscopy, BLI or MBA. But not all doctors use Lugol. We have some concern about Lugol. Maybe we are wrong, but we have some concern about that. And maybe Roberta can say her experience about that.
Can I ask you, what's your concern about?
Lugol, it's some pain in patients, and we ask for allergies. That's not a problem, but pain, it's our concern. Patient that not understand if they have pain, we have a big problem with the patient. I think that is our problem.
Yeah, it's true that sometimes you can have chest pain after Lugol spraying, but in that case, usually it can benefit only from a small amount of drug just to relieve the pain. The fact is that if you really explain to the patient what you are using and why you are using that one, because that make a real great difference to understand when the lesion. In the second case that I show, the colleagues, they were not able to find the lesion, and they sent the specimen to a different pathologist in a different city in Italy, because they were not really aware that it was SCC. It was not possible. There was no lesion. The lesion was there, and the Lugol really helped me in the line and define the lesion. So my personal experience of what I do, I don't use Lugol for every patient, of course, because the incidence in my country and in Western countries is very low. But for few patients, I explained before, and if there are no allergy of the iodine solution, I explained that can be the case of pain, but we'll do something for that pain. It's much more important to use the Lugol.
Unless you use it when you see something.
Yeah, the only case where I don't use is for very upper SCC, because in that case, I'm afraid of aspiration. But fortunately, they are rare case.
But Fernando, I think to your point, also based on what Roberta said, and at least a couple of RCTs, which have compared both Lugols and NBI or virtual chromoendoscopy, show very identical results. So from Roberta's presentation, what I gather is you can use either one. There may be select cases that you may be forced to use Lugols in that situation. But I think, Fernando, what you are doing, which is preferring electronic chromoendoscopy over Lugols, I feel that it's a very, sort of reasonable thing to do. Again, if you have it available. Cesare, other thoughts, other questions?
Roberta, it's quite difficult to detect this subtle lesion. So you like training young endoscopists. How to teach new endoscopists to detect this lesion? Should they attend a tertiary center, or can we use some video library? What do you think about it?
Yeah, the first thing is to know the classification and to see on the congresses, webinars, books, as much as you can of images, because you have to use your eyes and your mind on IPCL and BLI and MBI images. This is the first. Then to know the classification and to know how to apply. And for sure, go to a reference center, because even when they find in a small center this type of lesion, they used to correctly send to us. So this is the most important things. The things that I used to say is not to use the esophagus as just the passage between the mouth and the stomach, but to look at that organ. It's an important organ, and you should apply the same, how can I say, the same, you have to take care of the esophagus and to look for small irregularities, even a small one. What I used to do in a high-risk patient, I used to withdraw from the stomach directly on BLI, because the luminal side is small, so it's not a wide one. It's not like in the gastric side that you don't see really well. It's just a small one, it's cylindric, and it's easy to come back and withdraw on BLI or MBI.
Yeah, Roberta, what you said is very important. I know that also Pierre Desprez and all the Belgian association do like this also in community endoscopy. So it's very clever to withdraw in a light that may detect this lesion. And Prateek, you created the withdrawal time for Barrett, but you didn't create the withdrawal time for squamous. Maybe we need, I don't know, 1 minute for a centimeter or something like that.
Yeah, no, I mean, you're right. I mean, I think very important points that Roberta made about, improving the quality of endoscopy, which I think is critical to do. We are starting to get some questions on dysplasia and cancer, which tells us that it is time to move to the treatment talk. So again, grazie, Roberta, excellent. And then, Cesare, we'll have you introduce Haru and the topic, please.
Yeah, it's a great pleasure to introduce our friend who doesn't need any presentation, but serving as current president of the Japanese Society. So for Haru, to detect is not enough. He likes to treat. So please, Haru, tell us your tricks to treat this lesion. Welcome.
Yes, thank you very much. Introduction to me, the Cesare and the Prateek. Can you see my slides?
Yes, perfect.
Okay. So slideshow, let's go. Okay, so I'd like to talk about the endoscopic treatment. So surveillance and the detection is talked already by the Lawrence and Roberta. It's a great talks. And now I'd like to talk about the endoscopic treatment. So first, I'd like to briefly mention about the endoscopic mucosal resection. So this is a history. Peter Dyer is the first doctor who reported the jumbo biopsy. And after that, some Japanese followed his concept. And myself reported CAP EMR 1993, long time ago. This is a Toronto live demo. So this was 1995.
The position of the region, full suction, full endoscopic suction. Yeah, close, rapidly.
So assistant is the Dr. Rob House.
You can see the bottom, see the surface of the inner.
So this is the 26 years ago. Anyway, so this is another case. This is a dysplasia. So first the injection into submucosal, and then after that, so we keep yes. Now we make a pre-looping, and then approaching to the target tissue, and then suck it up. And then suck it up, and then make a shoot polyp and then resect it. This is a two times cauterization, makes a yes good resection. So this is a CAP EMR. So later it's extended to a duet or captivated. It's a band and the snare resection. So next I'd like to talk about the ESD. ESD is the first done by this doctor, Dr. Ono. The first target is a stomach, but after that, Dr. Oyama performed the first ESD in the esophagus. Now we perform the ESD using a multi-point traction technique. So it's one of the traction technique. So makes the procedure faster. Using the any snare, we can accept it, and fix it using the clip to the proximal end of the specimen. This is a sample of the large widely spread uncolored area. So in this case, we place the marginal cut first, and then now we are attaching the snare using several clips to the proximal end of the specimen. We normally place 3 clips. Then, so if we close the snare, the tissue, resected tissue is loading up. So we can approach the submucosal layer very nicely. Anyway, we keep cutting, and then finally we can make a good resection like this way without make an injury to the muscle layer. So next is an endoscopic muscle layer dissection. So I mean a little bit deeper layer we will approach endoscopically. So this patient is receives a CLT. So, but the tumor remains like this. So patient refused surgery and no lymph node swelling. So we talked to the patient and the family, decided to do the local resection. So tumor is a little bit hard and the thick like this. So Lugor staining. And then, so ultrasonography demonstrate the tumor invaded to the circular muscle layer. Anyway, we start the procedure, proximal incision after injection. Okay, so anyway, after exposing the proximal end, we place the multi-traction. So this patient receives the chemoradiotherapy. So submucosal layer is also there was a fibrosis. So anyway, so now you can see the surface of the muscle layer. There's some muscle layer component is attaching to the tissue coming up. Then we like this. So center of the tumor invaded to muscle layer. So we carefully dissect the muscle layer, not to dissect the tumor itself. Catch the soft tissue, and then cut the muscle, and then finally we resect the visible tumor like this way. So right after procedure, some defect of the superficial muscle layer, but not a full layer dissection. So next, conceptually, we can say subserosal dissection, but this is in the stomach, not in the esophagus. So next, we would like to demonstrate the case of endoscopic full thickness resection. This is a benign esophageal disease. Aberrant pancreas in the esophagus, very unusual. Aberrant pancreas is very popular in the stomach, but very unusual in the esophagus. So like this, so distal esophagus, there is the aberrant pancreas. So this is the orifice. So please note the orifice of the aberrant pancreas open and the pancreatic juice is coming out. So in this case, maybe I'm the first doctor perform ELCT from the esophagus. So you can see pancreatic duct. So our strategy is like this. So create a submucosal tunnel and they mobilize the aberrant pancreas and then resect all and then close the defect using clips. So actual procedures, the proximal of the lesion. After injection, we place the mucosotomy. And then in a submucosal space, we dissecting the aberrant pancreas. You can see a yellowish fresh pancreatic tissue. So this aberrant pancreas, this is a video at the time. So tumor embedded to the muscle layer. So we carefully dissect the root of the aberrant pancreas. Then finally all the specimen out. And then we close it intensively, placing the clips. And this was a benign aberrant pancreas. So this patient, before treatment, patient had esophagitis, inflammation of the aberrant pancreas every 3 months. And after this procedure, patient has no symptom, good clinical course. So this is all introduced. So thank you very much for your kind attention.
Okay, Haru, thank you. Wonderful. It's impressive every time I hear you. There's something new I see that you've done. When I think you cannot do anything more, you have mastered the boundaries, and you've done that. So can you please, I think for
Prateek, sorry.
Yeah, sure.
Sorry for interrupting. Can I mention that when Haru did that case in 1995, I was his assistant in Toronto. I was looking astonished at that procedure. And I took a couple of caps. I started doing my cap resection in Italy because of the caps that I got in 1995 from Haru.
Thank you, Alessandro.
So thank you, Ale. I think we've all learned watching Haru over the years to do it. So Haru, for people who are maybe not as brave and samurai like you, how about let's start with simple dysplastic lesions and M1 disease. What would you recommend to the broader audience? What is your approach? What should they start off with initially? Please walk us through those steps.
Yes, you are totally right. Of course, it's better to start the easy case. Easy case, what I mean is a intramucosal lesion. And the so mucosal region is easy to lift. Then we can perform easy EMR or ESD. So on the size, so lateral spread, lateral diameter should be 2 centimeter maximum. So please start the easy case. And then so you learn a lot how to do it, then approach step by step.
Okay, Cesare, you want to take? There are several questions in the Q&A session, please.
Yeah, the first question to Haru: when you do this advanced procedure for lesions that are advanced, what are the complications or the adverse event that we can expect?
Yeah, thank you very much. It's a very important question. And the EML ESD is the target is the mucosal lesion basically. Sometimes some minor invasion to some mucosal layer, so good. So if we approach muscle layer, so we have to be a little bit careful. After muscle layer resection, of course, we have to insufflate the esophagus CO2 only, not air. So otherwise, so patient have a severe emphysema. So we have to be very careful. And after resection, if we dissect some muscle layer, we have to keep the patient a little bit longer fasting. So carefully watching the patient post-procedure clinical course. So body temperature, inflammatory parameters, we carefully check it. And then, we decide the water drinking and the soft meal, like that step by step. And the full layer resection. So I think in the esophagus, our indication is very limited, like this benign patient. or it's a very specific patient who refused surgery or something, but it's a not a standard indication. It's a final indication. What I mean is the patient refused. So of course we have to recommend the patient receiving surgery. But the patient do not want to receive surgery, or poor risk patient, and then tumor size is limited, and no lymph node swelling, CAT scan and MRI. So in such a situation, we discuss with the patient and decide the indication. And the potential risk of the complication maybe a mediastinitis. So in the case of a full thickness resection, we have to close the defect using some overstitch. Dr. Repich is a good performer of overstitch, but myself using clips and some other technique. So anyway, closure is the most important.
Yeah, Haru, today we also had a case here of ectopic pancreas in the stomach. And so people were wondering, when should you resect an ectopic pancreas? Because I guess that most of the time you do not.
So your question is this case, indication of this
or
case?
In general, what are the indication for treating an ectopic pancreas?
So I think if we make a diagnosis beforehand, so at the time, so of course, if the patient has a several inflammation or some other, then a symptom or some other, so we can resect the tumor, I think, but not the tumor, so aberrant pancreas. But in the case of asymptomatic, so we have to discuss with the patient very carefully.
Okay, Cesare, I think in the interest of time, we will have the full panel come back after the next talk again. We look forward to talking to you again, Haru, in about 10 minutes. So yes, Cesare, please.
Yeah, so the last talk is from Yaroslav, where our best friend, Sergey, who co-authored several of our European guidelines, will bring us in the future. And so let's see if we can do something different with the AI. Welcome, Sergey.
Thank you very much, Cesare. My short talk is about artificial intelligence and post-endoscopy follow-up. Let me start from the artificial intelligence. Just a second. So endoscopy remains the gold standard for diagnosis of dysplasia and early squamous cell cancer. The ability to recognize endoscopic images depends on individual expertise. Let me show you the example from our live event, how to difficult interpret the details of mucosal and vascular structures, even for the experts.
Also the center, this is maybe some mucus and fibrin because of the chronic inflammation. Anyway, so this area also, so in a we call this area the brownish. The margin is not so sharp. Anyway, some proliferation of the duct, vessel duct. So IPCL, so on the IPCL type B1. So we can say if this is a cancer, so it's intramucosal, what I mean intraepithelial CIS. Anyway, no submucosal cancer. So we gradually advance endoscope behind. We can see some. We can coming back to white light image. This is leukoplakia. So. Hyperkeratosis of the mucosal surface. This suggests the patient has chronic inflammation. Anyway, so
so far no submucosal invasive cancer. Mucosal surfaces has lots of variety, lots of patches, and it shows different feature. So some part has the atrophy of the mucosa. So we can also remaining mucosa at the whitish patch like this.
So this is the difficult case even for the experts. And I think that a potential tool for improvement of endoscopic detection, differentiation, and making the decision is computer-aided diagnosis, especially if you need to make a clinical decision in cases which are not so common, for example, for non-expert centers, but which have already been equipped with high-end endoscopes. How can AI improve the detection of early squamous cell neoplasia? The group headed by Junka Fujisaki from Cancer Institute Hospital, Tokyo, was first to report a very good diagnostic performance of AI using deep learning to detect early squamous cell cancer from still endoscopic images. They retrospectively collected more than 800 training images of esophageal cancer. And the sensitivity for the comprehensive diagnosis was significantly higher than that in the white light imaging. In spite of some limitations, AI-based deep learning system demonstrated high diagnostic accuracy with high sensitivity to detect esophageal cancer with surprising efficacy. To improve the performance of CNN, authors analyzed the causes for false positive and false negative results. As you can see on this slide, half of the false positives were caused by normal structures and benign lesions. This can be, of course, corrected by deep learning. The other half of the false positives were shadows. It may be difficult for the CNN to differentiate the shadow from cancer because a shadow doesn't have a particular shape and changes in each situation. Analyzing still images, AI can evaluate only a limited area. So we need to analyze videos. In the recent study, the same group evaluated the ability of AI to detect early cancer from videos. The AI diagnosing system recognized 30 continuous frames of still images in just 1 second and detected cancer in the same manner as the analysis of still images. When the AI detected the cancer, it reviewed the video for 0.5 seconds, which means 15 frames. If the reviewed section included a cancer image in more than 3 frames, the AI diagnosed the lesion as cancer, giving a discovery signal. The authors evaluated slow speed videos, first of all, and achieve a detection rate of 100%. And then they examined the AI performance using high-speed validation videos. The sensitivity of artificial intelligence diagnosing system using high-speed videos was much higher than sensitivity of board-certified endoscopists and non-certified endoscopists. And their sensitivity was significantly improved up to 10% with AI assistant. As regards the characterization of the lesions, AI could predict submucosal invasion and differentiated stage T1A from T1B in endoscopic images. Let me show the results of our study where IPCL visualized on NBI magnification endoscopy, and these images were used to train our convolutional neural networks to detect the presence and staging of early squamous cell neoplasia. This CNN differentiated abnormal from normal IPCL with very high accuracy, more than 90%, and very high sensitivity, and classified abnormal IPCL patterns also with high sensitivity and specificity. We introduced a novel AI system capable to differentiate and classify IPCL. This is the good example of the characterization of early squamous cell neoplastic lesions. Finally, I would like to say some words about follow-up. Endoscopic resection is safe and efficient for the treatment of superficial esophageal squamous cell cancer, and Professor Inoue showed us the fantastic techniques and results of such kind of procedures. As for the follow-up, we should start first of all from staging, because the risk of metastasis strongly increased in patients with tumors with submucosal invasion. So we should focus on procedure, because the results of ESD, of course, is better than the results of recurrence after EMR. And during the follow-up, we should focus on metachronous lesions, because as we can see, the results of Taiwan group in 41 patients from 167 patients developed metachronous lesions during the follow-up. And finally, artificial intelligence tools is very important for detection, staging, and of course, follow-up. Thank you very much for your kind attention.
Sergey, wonderful, and congratulations on your excellent work in the field of imaging and artificial intelligence, which has really moved this thing forward. Cesare, over to you.
Yeah, so Prateek, I guess that what Sergey showed can be the solution to several problems. My only doubt, Sergey, is false positive activation, because Roberta said that you need to be trained with a lot of images to find a lesion, but you also need to be overtrained to discard a false positive. So how will a false positive affect the management of squamous cell lesion in community endoscopy?
So Cesare, it's difficult questions, because of course we need further studies on AI in detection and characterization of squamous cell neoplasia, because in the real practice, sometimes it's quite different even for the expert to differentiate neoplastic and non-neoplastic lesions because of the chronic inflammation. So such as after Lugol chromendoscopy, because after Lugol, we also could see a lot of unstained areas which are not neoplastic. Most of them are inflammatory areas. That's why I think that we need more studies, especially for the Western world, because as for Japanese studies, they have more early squamous cell cancers than for example, in Russia and in other Western countries. And that's why we should account, first of all, on their expertise, and then try to implement these studies for our systems and for our daily practice.
Okay, very nice.
I agree, Cesare. Sorry, I agree with you. It is the area for further investigations.
Good. Yes, I think this will be a topic which will keep coming back, not just for squamous cell, but as well as for other cancers as well. Before we, wrap up, I'd just like to go back to all our experts and probably ask them to tell us one important suggestion that they have for our entire audience from all over the world as to what they took away and what their recommendation is for the diagnosis and treatment of esophageal squamous cell cancer. So we will start off first with our panelists. So we'll start with Majda, then go to Fernando, and then to our speakers. Just, anything from either your experience, your expertise, your practice. What is one take-home message that you would like to give to our audience? Please, Majda.
Yeah, thank you so much for giving us this opportunity. So I think careful examinations of the esophagus, slow withdrawal, and examine the whole esophagus, and be patient when you examine is the most important thing. And try to train your eyes with the normal and abnormal. It's very important.
Okay, thank you. Fernando. Fernando, you're muted, sorry.
Oh, there. So I think like Mahida, it's always use chromendoscopy, BLI or MDI for esophagus examination. I think white light is not enough. And look carefully, take some time, because I think the simple is, or the first is to diagnose. After that, we can treat. But if we don't diagnose, we have problems.
Okay, very good message there that treatment can only be done with appropriate diagnosis. Now we will go to our speakers. So start off with you, Lawrence. And by the way, Lawrence, thank you for being up so late. I know it's probably midnight or close to that.
No, it's not as late as in Japan. Yeah. So what my message is quite simple. I think we do need to match. I think the risks. I think with the sort of operator. I think the matching has remained a sort of a challenge throughout. And as I mentioned, I think if the patient is high risk, I think we do have to pay particular attention, and then the operator also has to be equally as well trained. Otherwise, the mismatch will cause a lot of problems. And that is in some ways relates to Sergey's things about artificial intelligence. I think it's in a way that is helping us to reduce the mismatch. I think we have to be honest. I think you cannot have experts all over the world, and they're mal-distributed. We're talking about WEO. It's a world thing. It's mal-distributed, the resource everywhere. And then there are populations where you have a lot of disease load and you don't have enough doctors. So what do? And then you're bound to have problems. I think the thing is, as I see going forward, I think the mismatch is going to be the most important issues. No matter how good the medicine is and so forth, there is going to be mismatch. In some ways, you think I'm a socialist, but I think that's a fact of life. So hopefully, with all this technology, I think we reduce this mismatch, and then I think reduce the dependency on experts. I think we do need to continue to screen, obviously, and at the same time, I think try to do the best we can at the moment.
Very, very good and wise words, as always, from Lawrence. So, Roberta?
So already said all my important points, but just to focus on then, until we don't have the AI in our hands, let's say that we should use whatever we have. That means our knowledge. So get trained and get used and get familiar with SCC images and study as much as you can. Take care of the esophagus of your patient and take time to see and to have this withdrawal time that till now we don't know how much it must be. And use the black cap, use the chromendoscopy, digital chromendoscopy at first. And very small point we haven't mentioned because it was the, let's say, the initial phase for the diagnosis and a little bit of treatment. But just remember that this is an oncological endoscopy. So share all the patient with your oncological board or multidisciplinary team, whatever you call it, because the best treatment, we must choose the best treatment for that specific patient.
Okay, thank you. Very good. Haru is there. For him, I don't know, it is maybe 1 o'clock in the morning, but it's usual for him. He doesn't, I don't think he sleeps at all. I mean, I always, whenever I'm talking to him, he's in the same chair with the same background. So Haru, please, treatment-wise, your take-home points, please.
Yes. So the point of the esophageal cancer is when the patient receives a surgery, it's a very invasive surgery compared to the other organ. So gastric cancer surgery, colon cancer surgery, not so much invasive, but esophageal cancer surgery is so invasive. Everybody knows. That's the reason why it's better to detect early stage cancer. So simply don't miss, as Lawrence mentioned and Roberta mentioned, so don't miss the intramucosal cancer or slightly SM cancer. So that is a borderline of the lymph node metastasis or not. So please carefully watching the esophagus. And so Dr. Kashin mentioned, so AI in near future, now AI assisted to detect some mucosal cancer. Thank you so much.
Okay, thank you, Haru. There were a couple of questions as we were talking related to ablation of the lesions for squamous cell cancer. And the short answer is do not ablate, just resect. There are studies with RFA which show that it doesn't work as well as resection. So resection should be the key and not APC or RFA and stuff. So, we'll go to Sergey. And of course, Sergey, the task for you is you cannot repeat what has been said already. So please, I know you can do that.
Thank you very much, Prateek, for your kind invitation. We discussed very important topics. So screening, early detection, and treatment. I think that before we start any pilot national screening programs, it would be very important to create the special training programs for the doctors. For example, in Russia, we several years ago, we created together with Alessandro and Cesare the special program QACOL, Quality of Colonoscopy, and we have the fantastic results of improvement of adenoma detection rate. Then we created standards of upper GI endoscopy. I think it would be of vital importance to create some training programs for the doctors focused on the detection and early detection of neoplastic lesions in esophagus. And maybe artificial intelligence now it's a very important tool for the training of the doctors because it's based on a lot of cases. Thank you.
Okay, wonderful, Sergey. No, and I think it's the hope of the WEO esophageal committee to come up with some guidelines on the diagnosis and treatment. And several of you on this call are members of that and will be participating in the Delphi process. And I think, Sergey, your point about training is very important, and hopefully we'll get that done. And I think that's one of the reasons we selected this topic, because it's very important globally. Of course, we talk about Barrett's and reflux, which I would hope we continue talking always. But sometimes we have to talk, which is important more globally. And I think esophageal squamous cell cancer is that. So Cesare, of course, we will let you have the final word as always. So over to Cesare for wrapping this up.
Yeah, so Prateek, I felt somewhat guilty while I was listening to all of these talks, because here in the West, maybe we underrated somewhat the importance of squamous cell cancer in this year. So this initiative by this WEO committee is extremely important and also timely, because now we have the technology to detect this subtle lesion. But if we want to further improve our knowledge on this topic, I feel the best is to go to Kyoto, to ENDO 2022, where we can meet all of these outstanding speakers, and where WEO will continue to push on educational initiative for this important cancer. So Prateek, thanks to you, to the WEO committee, but really hope to meet you in live in ENDO 2022 in Kyoto.
Okay, and finally, you can see up on the screen the upcoming webinars, which are being planned by the WEO. So please keep track of this. And again, my thanks to each one of the experts. Truly a global event. We went from 7 a.m. or 6 a.m. in Chile and in the US to midnight in Tokyo, and we covered all different aspects of the disease, but also through global experts all around the world. So thank you to each one of you, the experts, for taking your time today to join this thing. Okay, thank you very much.